So good day. Today we're going to be talking about endometriosis. This is a term you probably heard. This is bulges around the uterus, as you can see, one around the fallopian tube and one around the ovary. So what are the risk factors for endometriosis? If you remember the risk factors for breast cancer, it's the same with endometriosis, like early menarche, or if you have nulliparity, when you don't have any children at all. The second one is iron deficiency anemia, if you're iron deficient, or if you have heavy bleeding in menses. These are correlated because usually if you have a heavy bleeding during your menstrual cycle, you're most likely to have iron deficiency anemia. If you do not exercise and you're physically inactive, your chances of having endometriosis is high. And then environmental factors like caffeine, taking too much coffee, alcohol, smoking, dioxins, and TCDD. What is dioxins? Dioxins and TCDD are like are toxins that are released from combustion areas. So these toxins affect our uterus and causes the endometrial tissue to be produced from in areas other than the endometrium. The endometrium tissue is just supposed to be around the endometrium, but when we have endometrial tissue around places like the fallopian tube or the ovaries or in the lungs or the kidneys, it's called endometriosis. When you have anatomical defect, obstruction, or familial clustering, this is the occurrence of disease within families. Okay, so let's have a question to spike our knowledge. Which of the following can increase the risk of endometriosis? Is it later age of menarche? Later age of menarche means the age after 14 years. Long menstrual cycle, like more than 30 days before your next menstrual cyst comes. Prolonged heavy bleeding during menses. This is when you have heavy bleeding. That means you have iron deficiency anemia, you have very low blood vessels, and then you have multiple parity. So which is the answer? Remember from this we said heavy bleeding in menses is a risk factor for endometriosis because it is believed that when you bleed too much during your menses, there is retrograde menstruation. That means your period goes back to the uterus, so chances of the endometrium forming around the uterus or around the fallopian tube or in the lungs or the kidneys is high. Another question is, the growth of endometrial implants in endometriosis depends on, what do you think? We have progesterone, estrogen, testosterone, and prostaglandin. So the answer is progesterone. Why is it progesterone? Remember, in your period, what happens is that the corpus luteum releases progesterone after ovulation to maintain the endometrial tissue, to make it grow ready for a baby to come. And when there is no baby, it sheds. So the progesterone is the right answer, responsible for this. Okay, so what are the symptoms of endometriosis? Your patient will come complaining of cyclic pelvic pain due to cytokinesis production and pain. It depends on how deep it goes into the endometrial tissue. We don't really care about how many endometrial tissue is around the uterus or the fallopian tube. We just want to see how deep does it go, because the deeper, the more painful. So the second one is dysmenorrhea, a fancy word for period pain, dysuria, pain while urinating, dyspareunia, pain during sexual intercourse, diachexia, pain while defecating, and then we have infertility and subfertility. Usually patients with endometriosis, around 10%, are infertile. And then we have hemothorax. Hemothorax is when you have pleural cavity, water in the pleural cavity, and when the endometrial tissue is found in the lungs, you are most likely to have hemothorax. Next is our treatment plan. So in general, the NSAIDs and the contraceptives and the progestins are recommended as first line due to their proven success in dysmenorrhea management, tolerability, and cost. But remember, contraceptives is only used in patients who do not wish to be pregnant, as well as the progestins. The GnRH agonist, if you remember, GnRH is released from the hypothalamus to alert the anterior pituitary gland to secrete FSH and LH. So if we have GnRH agonists, they are going to look like the GnRH that is released from the hypothalamus. So your anterior pituitary will think, okay, since we have too much GnRH agonist, that means we don't have to release FSH and LH. We call this the negative feedback. And danazol is an anti-androgenetic drug. It's highly effective and it's considered second-line therapy. We also have the aromatase inhibitors. They're like the last line, and we usually don't even use it because FDA have not approved these drugs. And for asymptomatic patients with an incident diagnosis of endometriosis, they do not need treatment because we just watch them since they are not in pain. They don't have pain during urination, they don't have pain during defecation, they don't have pain during sexual intercourse, and they're not infertile. So we just watch them and monitor them for development of pain or infertility. Remember, the first line therapy for endometriosis associated pain includes oral contraceptives. The CHC means combined hormonal contraceptives, oral progestins like norethindrone acetate or medroxyprogesterone acetate, or the depoprogestin medroxyprogestin acetate, DMPA. They're like the implants that we put in people to release progestin slowly into the body. So what's the diagnosis? So usually we do manual examination, we insert our hand and feel if there's any endometrial tissue around the uterus, or we do laparoscopy. So the contraceptives, we give a low dose, 20 to 30 microgram of ethyl estradiol, which is monophasic. It's a constant dose. And patients who don't, but we only use this for patients who do not have relief from NSAIDs and who don't wish to get pregnant. We could also give them progestins, but this is for patients who we can't give COC. If your patient is not going to take COC, patients who have contraindications from COC, like smokers, like pregnant ladies, patients who have hypertension, history of hypertension, we can't give them COC, so we could give them progestins. They are administered orally. We have this drug and this drug as well, IM or subcutaneously. And the patients may experience amenorrhea, that's a cessation of menstruation, and decrease in bone density after prolonged use. Next is we could use GnRH analog. Remember I said GnRH analog are like they mimic the GnRH to make our anterior pituitary gland think that we have a lot of GnRH, so let's stop the production of LH and FSH. But we only give this drug if COCs, that's a hormonal contraceptive, or progestins didn't work, because it causes irreversible bone density loss. So we don't want our patient to have irreversible bone density loss and then menstrual symptoms. Hence, it's used as second line. Used only after other treatments fail. Just recall this whenever you have a case, and then in the case, they tell you that the patient have never used any COCs or progestins, but he had been on NSAIDs. Do you recommend GnRH analog? Say no. Use COCs if the patient doesn't want to be pregnant first, and if it's not working, then you can go into the GnRH analog. And then you have to remember from pharmacology, they initially flare up estrogen and progesterone at first after taking the drug, because your body will think, boom, we have a lot of GnRH analog. What does it mean? We want more estrogen, and then suddenly you're going to have an inflated estrogen and progesterone, and then it desensitizes the receptors because the high progesterone and estrogen keeps telling the pituitary, stop, 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 we have enough, and then it decreases the FSH and LH levels, then which stops the pain. Gonadotropin agonists, example are the antagonists, are like the fighters. They go to the gonadotropin receptor on the pituitary and they stop and block it from binding. What does it block? It blocks the original GnRH that is released from the hypothalamus. It blocks it from binding to the receptor on the pituitary hormone, on the pituitary gland. So it won't know that, okay, is it too much, is it too low? Since it's blocked, that means we don't need more, which rapidly decreases the estradiols and gonadotropins in the body. So like I said, it competes with GnRH to block the receptor on the pituitary. So danazol is another drug that is given for 6 months at least, only 6 months, because it has a lot of side effects which includes weight gain, voice changes, we have edema, acne, hot flashes, all these symptoms are unbearable and intolerant from our patient. They also have hirsutism around their neck, liver disease, and it increases cholesterol. AI, they're the aromatase inhibitors. How they work is they stop the production of androgens. Usually androgens transform into estrogens in our body. And remember, too much estrogen is responsible for the growth of intramural tissue, which could be as a result fall on the surface of the uterus, ovaries, or in the fallopian tube. So if we stop the amount of estrogens in the body by inhibiting the enzyme that is responsible for transforming androgens to estrogens, we could inhibit the action, which reduces the pain. But it is not approved by FDA and it has fewer side effects like hot flashes. And for severe disease, what we do is we do excision, which means we put like a fire to burn the tissues around the uterus, the endometrial tissues that we don't want them there. We could do fulguration. Instead of fire, we use high electric current, and then the laser, we use laser ablation to remove the ectopic tissue. So a few questions for the day. They said gonadotropin agonist, aromatase inhibitors, and dipomethylprogesterone all share the potential for which of the common side effects? So if you remember, they all causes one very important side effect, which is the bone mineral density loss. Next is EL is a 37-year-old woman who with controlled hypertension, endometriosis, and tension headache. She takes verapamil ER 180 mg daily and ibuprofen. Remember, ibuprofen is NSA. Verapamil is an antidepressant for her tension headaches. She smokes. This is very important because whatever drug you would like to prescribe, as long as the patient smokes, you can't give her a COC. And she drinks a glass of wine each night. A few years ago, she had a laparoscopic procedure that reduces most of her pain, but it is returning. She is now interested in medical treatment. Which of the following represents a contraindication to her use of combined hormone contraceptives to treat her endometriosis pain? Let's remember, we can't give her combined hormonal contraceptives, that's the question. But why? Because she smokes. If you remember from the last video, we said one of the contraindications of hormonal contraceptives is people who smoke. So as long as you smoke or you have high BP, not the controlled, the uncontrolled high BP, you are not allowed to take contraceptives. And if you have migraine, not tension headaches, you can't take hormonal contraceptives. So our next question is, RP is a 21-year-old unmarried college student with severe endometriosis pain that has been unresponsive to 6 months of treatment with dipomethylprogesterone, remember. Her past medical history includes asthma, which is very important because asthma, migraine with aura, and anxiety. Her medication includes citalopram, which is an antidepressant, fluticasone, salmeterol, it's for asthma, and albuterol for asthma as well. She also takes sumatriptan. Which of the following treatment recommendation will be best for RP? Okay, one thing we have to remember is she has migraine with aura and she has asthma. So one thing we can give her is the combined hormonal contraceptives. We can't give her contraceptives because she has migraine, she has asthma, and she's taking citalopram as well. So contraceptives is cancelled, and we can't give her this taclopyrrolide, estradiol, and norethine acetate. It's also cancelled because it's a contraceptive. This is a progesterone drug. So the only drug that doesn't have any contraceptive, this is contraceptives as well. It's an IUD, is a progesterone only contraceptive. So the only option is to give her a low dose combined oral contraceptive. Is to start letrozole and oral methylprogesterone acetate. Letrozole. So we can't give our patient this or the last drug. We could only give her the letrozole and oral methylprogesterone acetate. Thank you so much. I hope you enjoy. If you have any questions, don't forget to ask.